Someone get the light, please. So we're starting on chapter 43, drugs affecting blood pressure. Your first three drugs, or drug classes, I should say, for your drug cards are going to be your ACE inhibitors, your ARBs, yep, angiotensin receptor blockers. Your ACE, your ARBs, your calcium channel blockers. So that's 3. Now on the next page, your vasodilators, that's 4. Very important, number 5, your beta blockers. And your vasopressors. So what's that, 6, right? So let's go back to page 728 because I want to bring some things to your attention before we begin. Notice your ACE inhibitors and in Prill. And so I want to tell you guys, I remember when I was in the nursing program, she wasn't really my nemesis, we were friends, but academically she was my nemesis. Her name was April, because she would always ace her exams, and so would I. She was Jamaican, I was Haitian, so we would represent for our country, right? So after each exam, we would always compare to see who got the 100 and who got the 98. So I would always remember April always aced her exam. So these medications that end in April, you can remember those are your ACE inhibitors. I hope that helps. The ARBs, the angiotensin receptor blockers, notice that most of them end in what? Sartan. Your calcium channel blockers, by the way, the ones that show up the most on NCLEX, if they ask you about a calcium channel blocker, it is amlodipine. But I don't write the exam, so who knows what you're going to get. But notice most of them end in peen. Next, your vasodilators. For NCLEX, if you get a question about a vasodilator, mostly they ask about either the hydralazine or the nitroprusside. So make sure you know those and make sure they fall under the vasodilator category. And your beta blockers, they end in LOL. And the one that's asked most are these two. I don't know why they put a star next to them, but your metoprolol and your propranolol. Make sure you know that those are beta blockers. And your vasopressors. The ones that, if you get a question on NCLEX, the ones they ask about the most is your dopamine, your dobutamine, definitely epinephrine, norepinephrine. Okay, so when you're doing your drug card, same thing, guys. You're going to do it by class, but you have to know the medications that fall under that class. Does that make sense? Yes. All right. Let's get started. Page 729. For you. So we're going to do a quick little review of blood pressure control. The pressure in the cardiovascular system is determined by 3 elements. The heart rate, the stroke volume, and peripheral resistance. Heart rate, you guys know what that is, your stroke volume. Amount of blood that's pumped out of the ventricle with each heartbeat. And the total peripheral resistance, that's the resistance of the muscular arteries to the blood being pumped through. The more resistance that there is, guys, the higher the blood pressure is going to be. Baroreceptors. As the blood leaves the left ventricle through the aorta, it influences specialized cells in the arch of the aorta called baroreceptors. These are the pressure receptors. If there is sufficient pressure in these vessels, the baroreceptors are stimulated, sending that information to the brain. So guys, these baroreceptors are what basically controls to make that blood pressure go up or down. If the pressure falls, the stimulation of the baroreceptors falls off. That information is also sent to the brain. And that brain can tell your vessels to go ahead and constrict or go ahead and dilate? Remember, when those vessels constrict, does the blood pressure go up or down? Up. And when they dilate, the blood pressure goes down. Okay. Page 731. Hypertension. Of people with hypertension, 90% have what's called essential hypertension or hypertension with no known cause. What's that other word when we don't know what causes it? Very good, very good. The underlying danger of hypertension of any type is prolonged force of the vessels of the vascular system. Remember, all that the high blood pressure is the force of the blood pushing against those vessels. The muscles in the arterial system eventually thicken, because remember, your body's made to protect itself no matter what, even those vessels, guys. So chronically, long term, if the blood and fluid in the vessels keep pushing, what happens? The vessels actually start to thicken because it's trying to toughen up, right? This is what's happening. The arterial system eventually thickens, leading to a loss of responsiveness in the system. The left ventricle thickens because the muscle must constantly work hard to expel blood at a greater force. So let's think about this for a second. The left ventricle thickens. Well, the left ventricle, where does it push blood to? The body, right? Yeah, the left ventricle, eventually that blood is supposed to go to the body, it's supposed to go to the brain, the organs, everything. If it starts to give up and it's not pumping blood to the body, where does that blood back up into? The lungs. Exactly. Very good. All right. Page 732. Untreated hypertension increases the person's risk for coronary artery disease and cardiac death, stroke, renal failure, and loss of vision. Let's stop right there because this is very important. So if that high blood pressure consistently and it doesn't get treated, the person's at risk for coronary artery disease. Remember, guys, those coronary arteries, just like we have arteries that feeds our heart, our kidneys, our spleen, our liver, the heart muscle itself needs blood, oxygenated blood, and it's the coronary arteries that brings that oxygenated blood, okay? So that's very important. Because hypertension has no symptoms, it's difficult to diagnose and treat, and it's often called the silent killer. Most people don't even know they have high blood pressure until they have their first stroke. And hopefully they survive that stroke. That's why hypertension is known as a silent killer. You know, all other diseases, you have pain, something's wrong, you go to the doctor. But with hypertension, people walk around and have no clue, usually until they have their first stroke. This is all over NCLEX, and I don't care what state that you're testing for, because it's so prevalent, you're gonna see this, make sure you know this. Factors that are known to increase blood pressure in some people include, and it's always a select all that apply, guys, high levels of psychological stress. Stress at work, your spouse acting up, your kids acting up. Nursing school, yes. Psychological stress, exposure to high frequency noise. High salt diet. Why? Because salt attracts what? Water. And that fluid pushes against the vessels even more. Lack of rest and genetic predisposition. Again, make sure you guys know this. You're going to see that select all that applies. Now let's look at box 43.1. Let's jump down here. So what's very important for you guys to know, have to know your normal. Normal blood pressure is less than 120/80. Patient gets into stage 1 once they hit 130. 130 to 139 systolic, 80 to 89 diastolic. Remember, systolic's the number on the top, diastolic's the number on the bottom. Make sure you guys know these two.
What about the elevated?
What about it? What was the question?
Elevated. like if a patient has an elevated blood pressure?
You have to start warning them because they're about to go into stage 1 hypertension. So we don't wait until they're actually get that diagnosis of hypertension that we start teaching them that they need to start eating food with fiber, they need to start exercising, they need to stop eating so much salt. So we're seeing this so we can, that elevated, that's when we start warning the patient, hey, you're not normal anymore. You're about to be hypertensive. This is what you need to do to stop it.
Okay. Wait, are you going to prescribe, but if, as a nurse practitioner, would you prescribe?
No, I don't start prescribing medications until they're I actually give them that diagnosis of hypertension. And honestly, even with that diagnosis of hypertension stage 1, depending on the other patient's comorbidities, I might not order a medication. I might still try exercise and diet, but I'll have them follow up more closely than I would other patients to see if I can get that blood pressure down. And if I can't, I'll start them on medication. But remember, we always want to do least invasive to most invasive. So we always want to try, diet, exercise, anything that the patient doesn't have to start taking medications yet, if it's possible. If a patient has stage 1 hypertension, and remember guys, that stage 1, again, the systolic is 130 to 139, diastolic 80 to 89. If a patient has stage 1 hypertension and has cardiovascular risk, remember those cardiovascular risks, guys? We just talked about them. So if they have stage 1 and they have cardiovascular risk, it's recommended that medication to treat blood pressure is started. It's recommended that all people, all people with stage 2 hypertension be started on medication. So when the patient's in stage 1, there is some leeway depending on what other risk factors they have. But once they hit that stage 2, they have to go on medication. Treatment guidelines, very important, you guys have to know this. Non-Black patients, including diabetic patients, may initiate treatment with a thiazide diuretic. We talked about those diuretics already, calcium channel blockers, ACE inhibitors, or ARBs. If they are not Black, again, if they're not Black, and they can be a diabetic, that's fine. We can start them on thiazide diuretics to get the blood pressure down, calcium channel blockers, ACEs, or ARBs. However, Black patients, including if they're diabetic, okay? Black patients may initiate treatment with a thiazide or thiazide-like diuretic or calcium channel blocker before ACE inhibitors or ARBs due to better effectiveness. Study after study after study has shown that ACE and ARBs do not work as well in patients of African descent. That's very important for you guys to know. You're going to see it again. Patients 18 years or older with chronic kidney disease should initiate treatment with ACE or ARB. An ACE inhibitor and an ARB should not be used together in the same patient. So either they're going to get an ACE or they're going to get an ARB, but they're not going to get both. If the goal of blood pressure cannot be reached using only one of the drugs recommended or a contraindication or the need to use more than 3 drugs to reach a goal, referral to a hypertension specialist may be indicated. So that's the time that the nurse practitioner or the physician is going to punt that patient to cardio and let them deal with it. Okay? Look at box 43.2. White coat syndrome. So very often, guys, a patient, their blood pressure will go up just because they're at the doctor's office. It's called white coat syndrome because the clinicians wear the white coats, right? So that's important for you guys to know. The American Heart Association has put forth new guidelines for the diagnosis of hypertension. A patient should have at least, how many? Two consecutive blood pressure readings above normal when taken by a nurse-trained technician over a period of 2 to 3 weeks. Whoever's taking the blood pressure should attempt to have the person relax prior to the assessment because we are aware of white coat syndrome. You're going to select the cuff that's the correct size for the patient's arm. A cuff that's too small is going to give a higher than normal reading, and a cuff that's too large is going to give a lower reading. You have to know that. Try to put the patient at ease, have them relax. Ensure that the arm will be used for the, ensure that the arm that will be used for the cuff is supported. Make sure the rest of the patient's muscles are not tense. Box 43.3. Anti-hypertensive therapy. African Americans are at highest risk for developing hypertension, with men more likely than women to develop the disease. African Americans have documented differences in response to anti-hypertensive therapy. For example, African Americans are most responsive to single drug therapy as opposed to the combination drugs. They're more responsive to diuretics. That's why when it comes to the African Americans, usually that's the rule of thumb. We start them on either a thiazide or thiazide-like diuretic. Okay, they're more responsive to diuretics, calcium channel blockers, and alpha adrenergic blockers. They're less responsive to ACE inhibitors, ARBs, Renin inhibitors, and beta blockers. Again, guys, this is on NCLEX. This is like the third time they're telling us the same piece of information. Why? Because it's important for you to know.
What is it that they have that makes it so different?
Something in genetics. Something in genetics. What is that word? I told you guys about a couple weeks ago. Something it's a pharmacology, but based on genetics. And so they found something like on the DNA strand that the people of African descent have that others don't. Or something on the DNA strand that they're missing. But I think it's something that they have that most of the people don't. So those messages don't work. Pharmacogenetics, that's what it's called. Pharmacogenetics. Screening for hypertension among African Americans is important for detecting hypertension early and to prevent organ damage. Organ damage such as what? Kidneys, your eyeballs, right? People lose their vision. Because African Americans are more responsive to diuretics, this is like the fourth or fifth time we're seeing this, guys. The treatment approach should include the first line, ding, 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 first line, the first line use of diuretic in combination with diet and other lifestyle changes. Key points. Heart rate, stroke volume, and peripheral vascular resistance are the factors that determine blood pressure. A decrease in blood flow to the kidneys triggers RAAS, by which the blood vessels constrict and water is retained. This activity increases the blood pressure and restores blood flow to the kidneys. Hypertension is a sustained state of higher than normal blood pressure that can lead to blood vessel damage. Remember, because those blood vessels start to thicken. Arteriosclerosis, what happens when you eat fatty foods, that fat, that plaque starts to stick to the inner lining of the vessel and damage to small vessels and organs, such as your eyeballs. The cause of essential hypertension, again, guys, is unknown. Maker cells of the SA node of the heart. When you see SA node or hear SA node, I need you to think of what? Pacemaker, yes, that is the pacemaker of the heart. The SA node is what starts the impulse, okay? Let's jump to page 717. Key points. The heart, a hollow muscle with 4 chambers comprising of 2 upper atria and 2 lower ventricles, pumps what type of blood? Oxygenated blood into the body cells. And it pumps deoxygenated blood to the tissue, to the lung tissues, because remember that blood is deoxygenated. That's why it's even going to the lungs to pick up the oxygen. Remember diastole, that's resting period when the veins carry blood back to the heart. And systole, this is a contraction period when the heart pumps blood out to the arteries for distribution to the body. ECG, Electrocardiography. An electrocardiogram, ECG, is a measure of electrical activity. It provides no information about the mechanical activity of the heart. It only measures the electrical activity, guys. You see this? The important aspect of cardiac output, which is the degree to which the heart is doing its job of pumping blood out to all the tissues, needs to be carefully assessed by looking at and evaluating the patient. The patient always comes before the machine, every single time. The normal ECG waveform is made up of 5 main waves. The P wave, which is formed as impulses originating in the SA node. Remember that SA node is a pacemaker of the heart, or pacemaker passes through the atrial tissues. The QRS complex. This represents depolarization of the bundle of His. Q and the ventricles, RS, and the T wave, which represents repolarization of the ventricles. Page 718. The P wave immediately precedes the contraction of the atria. The QRS complex immediately precedes the contraction of the ventricles and then relaxation of the ventricles during the P wave. The repolarization of the atria occurs during QRS complex and is usually not seen on the ECG. Arrhythmias. A disruption in the cardiac rate or rhythm is called arrhythmia or dysrhythmia. People use it interchangeably. Various factors such as drugs, acidosis, decreased oxygen levels, changes in electrolytes in the area, buildup of waste products can change the cardiac rate and rhythm. Page 719. A faster than normal heart rate, usually anything faster than 100 beats per minute in an adult with a normal appearing ECG pattern, is called sinus tachycardia. Sinus, which is normal, tachycardia, which is high heart rate. Remember, guys, the normal rate is supposed to be 60 to 100. Many activities or conditions can cause sinus tachycardia, such as, and you need to know this because NCLEX is asked about this: exercise, fear, or stress. So your heart rate will be increased, but there's really nothing pathological happening. If somebody's trying to rob you, your heart rate's going to be increased, right? But it's not an illness. Sinus bradycardia. So remember, bradycardia is lower than normal heart rate. So if your heart rate's supposed to be 60 to 100, and it's sinus bradycardia, is it going to be lower than 60 or higher than 100? Yes, lower than 60. Sinus bradycardia is slower than normal heart rate, usually less than 60 beats per minute, with a normal appearing ECG pattern. This is often seen with athletes. This is on NCLEX. It's been seen on NCLEX. Make sure you know it. Who have a slow heart rate. So sinus tachy, we see this in patients who are, experiencing stress, or they're exercising, or they're experiencing fear at the moment. And sinus brady, we often see this in athletes. Key points. When the generation of impulses is altered, the result is known as arrhythmia or dysrhythmia. That can upset the normal balance in the cardiovascular system. If there's a resulting decrease in cardiac output, that means decrease of blood, oxygen, vitamins, nutrients that's going to the body, all of the cells in the body will be affected. Page 722. We're going to go over heart, preload, afterload, and contractility. Heart. The more the heart has to pump, the more oxygen that it requires. Remember, just like all your organs need oxygen to function, so does the heart muscle itself. Look at that right here. I wrote heart tissue needs perfusion. And remember, perfusion is how much the organs are being fed oxygen, vitamins, nutrients. Preload. Preload, this is the amount of blood that's brought back to the heart to be pumped through the body. The volume of blood in the system is a determinant of preload. So if there's lots of blood in the system, obviously the preload is going to be up or down. It's going to be increased or decreased? Increased, because all of that body that's in the system is what's going to the heart. Afterload. This is resistance against which the heart has to be. Blood pressure is a measure of the afterload. Because again, guys, remember, blood pressure, all it is that resistance against the vessels. And the more fluid that there is, the more resistance there's going to have to be, right? It makes sense. Contractility. This is increased with more influx of calcium into the heart cells. Systemic arterial pressure. The contraction of the left ventricle, which sends blood surging out of the aorta. Remember, guys, that left ventricle, that's the one that pushes blood to the lungs or to the body? Very good. It creates a pressure that continues to force blood into all the branches of the aorta. This pressure against arterial walls is greatest during when? Systole, contraction. It makes sense because it's squeezing all of that blood out. And it falls to its lowest level during diastole. I can't speak. Thank you. Diastole. Because remember, that's when those muscles are relaxed. So hypotension, when the blood pressure is low. Hypotension, from loss of blood volume, it can happen from excessive vasodilation, because we know when those vessels dilate, the blood pressure goes down. Or from failure of the heart muscle to pump effectively. All of those can cause hypotension. Severe hypotension can progress to shock and even death, because what happens, guys, when the blood pressure is low, not enough blood, oxygen, vitamin, nutrients are getting to these organs, the organs are going to start to shut down. And when this happens, guys, what's the first organ that always shuts down? Kidneys. Yep. So seeing urine output drop, that is usually our first sign that something's going on with this patient as far as what's the word I'm looking for? Organ failure, shock. Okay. Now let's talk about hypertension, increased blood pressure. This puts a tremendous strain on the heart muscle, because if the blood pressure is increased, that's more resistance for those muscles. Hypertension can be caused by neurostimulation of blood vessels that causes them to what? Constrict. Remember, with constriction, the blood pressure goes up. Subsequently raising blood pressure, or by increased volume in the system. And that makes sense, because the more fluid volume you have, that's the more pressure that's going to be pushing against the vessels, which means more resistance, which causes the blood pressure to go up. It's like a domino effect. Renin, angiotensin, aldosterone system. Another determinant of blood pressure is the renin, angiotensin, aldosterone system. This system is activated when blood flow to where? Kidneys. The kidneys. When blood flow to the kidneys is decreased. The juxtaglomerular cells near the afferent arterioles in the kidneys release an enzyme that's called renin. Renin is then transported to the liver, where it converts angiotensin to angiotensin 1. It's a domino effect, guys. Angiotensin 1 then travels to the lungs, where it's converted by angiotensin converting enzyme to angiotensin 2. Angiotensin 2 then travels to the body and reacts with angiotensin 2 receptor sites on the blood vessels to cause a severe vasoconstriction. That severe vasoconstriction, is that going to make the blood pressure go up or down? Up. This increases blood pressure and should increase blood flow to the kidneys to decrease the release of renin. Like angiotensin 3, it also causes the release of aldosterone from the adrenal cortex. Remember, we talked about the adrenal cortex. Remember, they're located right on top of your kidneys? You take your two hands, put them behind your back like this, right where your palms are. Those are your kidneys, and they sit right above your kidneys, okay? So it causes the release of aldosterone from the adrenal cortex, which causes retention of sodium and water. Just the fact that this is causing retention of sodium and water, are we expecting blood pressure to go up or down? Ah, very good. So it causes retention of sodium and water and stimulates the release of anti-diuretic hormone. Remember, anti-diuretic hormone is what makes you hold on to your fluids. It makes you not urinate. So it stimulates the release of anti-diuretic hormone from the posterior pituitary to retain water, both of which increase fluid volume. Page 724, heart failure. If the heart muscle fails to do its job of effectively pumping blood through the system, blood backs up and the system becomes congested, and this is what's called heart failure. And usually people end up getting left-sided heart failure first, and it develops into right-sided heart failure. But what you got to remember, that left side of the heart is responsible for pushing all of that oxygenated blood out to the body. And for several reasons, maybe the patient has too much fluid, whatever's going on with them, that heart muscle's too weak and it can't pump all of that blood out to your brains, to the bottom of your toes. It backs up, it backs up, it backs up, it backs up, it backs up to the lungs where that fluid came from. And that's why you'll see those patients, when the patient has left-sided heart failure, they're going to have lung issues such as shortness of breath, dyspnea. Right-sided heart failure, this is blood that was supposed to go to the lungs to pick up oxygen. Now, it's not working properly, so it backs up to the body. Right-sided heart failure, rest of the body, we see symptoms in the rest of the body, such as splenomegaly, such as what's that word when you say what's it? Ascites, yes, ascites, and we see that pedal edema, right? So right-sided heart failure, that's the rest of the body that we see, just those signs of fluid overload, distended jugular veins, and with left-sided heart failure, we see all of those lung symptoms. So that's something you want to keep in mind. Page 725, summary. Important things to keep in mind. The cardiac cycle consists of a period of rest, also known as what? Diastole, very good, when blood pressures return to the heart by veins, and a period of contraction known as systole, when blood is pumped out of the heart. In normal sinus rhythm, cells in the SA node, they generate the impulse that's transmitted through the atrial bundles and delayed slightly at the AV node before being sent down to the bundle of His into the ventricles. When the cardiac muscles are stimulated, they contract. Now, that SA node is also known as what, guys? The pacemaker of the heart. Very good, because that's what starts that impulse. The heart muscle needs constant supply of blood, which is furnished by the coronary arteries. Those are the arteries that are responsible for bringing oxygenated blood to the heart muscle itself. All right, now let's go back to chapter 43, page 735. So remember that whole angiotensin, Renin, angiotensin, aldosterone system we talked about? We're seeing it again. There, page 735, towards the bottom. All right. So we're going to call that renin, angiotensin, aldosterone system RAAS. So when you hear RAAS, that's what we're talking about, because I'm not going to keep saying that whole thing. RAS, okay, there we go. The RAS is one of the body's main reflexes for maintaining blood pressure. Remember that whole domino effect? In the absence of a known cause for hypertension, one approach to lowering blood pressure is to affect the reflexes that control blood pressure, which is the RAS. 3 classes of drugs have been developed to alter the RAS. The angiotensin converting enzyme inhibitors, those are your ACE inhibitors. They block the conversion of angiotensin 1 to angiotensin 2. So that's one way we fight the RAS, right? The ARBs, which block angiotensin receptor sites on the blood vessels. And the third one is a renin inhibitor. So those are the three drug class guys that affect the ARB, which will help bring down the blood pressure. Page 736, box 43.1. Your ACE inhibitors, again, notice guys, they end in pril. Just make sure you can recognize ACE inhibitors when you see them. Page 737. Your ARBs, notice they end in sartan. And your renin inhibitor. Page 738. Calcium channel blockers. Most of them end in P. Your vasodilators. Your diuretics. Let's jump to page 739, box 43.7. Step care management of hypertension. You are going to see this on your NCLEX for RN, but if you go on to be do nurse practitioner, you're going to see this again. As a matter of fact, they kill you on the FP exam with this. Give me 1 second, guys. All right, so the step care. The first thing we're going to try is lifestyle modification, okay? What are we going to teach them? You have to know all of this, guys, because this is what you're going to be teaching these patients. You're going to teach them to lose weight, stop smoking, drink moderation of alcohol. So we don't, like, you know, when it comes to smoking, it's always cessation. We always tell them to stop. We never say slow down or smoke a little bit. They need to stop. But with alcohol, we tell them to drink in moderation, okay? So they don't have to stop. They just can't drink too much. We tell them to reduce the salt in their diet. Now, let me stop here for a moment because there's something that shows up on NCLEX, and like, I know you guys don't do it here end of semester like HESI or ATI, but lots of schools do. And something that shows up on those exams as well, if a patient, let's say they have heart failure, right? And you're teaching this to them, you have to also teach them when it comes to reduction in salt diet, they have to be careful with salt substitutes because salt substitutes are high in potassium. And potassium affects what? The heart. That can cause that patient to have dysrhythmia. So just keep that in mind, okay? You're going to teach them to reduce salt in the diet. You're going to teach them to increase exercise. That doesn't work. Let's say it doesn't work. We're going to move on to step 2. Now, when we move on to step 2, we're going to do everything in step 2 plus step 1. So it's not like they have to stop exercising just because they're on meds now. No, they're going to be on their meds, but they still have to do everything we taught them in step 1. So in step 2, if we don't have an adequate response, we're going to teach them to continue lifestyle modifications. Everything we talked about in step 1, they have to continue it. If the measures in step 1 are not sufficient to lower blood pressure to an acceptable level, then drug therapy is added. Diuretics, we're going to help them get rid of fluids because the more we get rid of fluids, we expect that blood pressure to go down because there's going to be less resistance, right? ACE inhibitors, the patient can get ACE inhibitors. Remember, the job of the ACE inhibitors, they block the conversion of angiotensin 1 to angiotensin 2. And I'm not big on the actions of drugs most of the time, but for this, you do have to know the action. You have to know the difference of how they lower the blood pressure. Where the diuretics lower the blood pressure by getting rid of the fluids, ACE inhibitors lower the blood pressure because they block that conversion of angiotensin 1 to angiotensin 2. Calcium channel blockers. How do they work? How do they lower the blood pressure? They relax muscle contraction. Remember, guys, with contraction, with constriction, the blood pressure goes up. So if the calcium channel blockers relax that muscle contraction, it makes sense that it's going to help the blood pressure to go down. And angiotensin 2 receptor blockers, how do they work? They block the effects of angiotensin on the blood vessel itself. You guys have to know the difference in the actions, okay? So let's say we put the patient on those meds plus the lifestyle modifications. Still didn't work. Right? We still have an adequate response. We have to move on to step 3. What is step 3? Consider change in drug dosage or class. which the nurse practitioner or physician is going to do, or addition of another drug for combined effect. And this last part where they say or addition of another drug for combined effect, most likely we're talking about patients that are not what? African American or of African descent, because drug combinations really are not effective for them. Okay, remember we have to keep that in mind. Oh, sorry guys. So let's say that didn't work. We're moving on to step 4. All of the above measures are still continued, and a second or even a third agent or diuretic is added. It's something they didn't put on here, but most likely what happens, that's when the NP or the physician sends them to cardio. All right, let's talk about ACE inhibitors. The ACE inhibitors include the following agents. You see this list, make sure you know them, make sure they're on your drug cards. Therapeutic actions and indications for ACE inhibitors. ACE inhibitors act on the lungs to prevent ACE from converting angiotensin 1 to angiotensin 2, a powerful vasoconstrictor and stimulator of the aldosterone release. This action leads to a decrease in blood pressure and in aldosterone secretion with a resultant slight increase in serum potassium and loss of sodium and fluid. Pharmacogenetics, you guys know I don't usually go over them, so if I'm talking about it, you need to know it, right? All, ding, 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 all of the ACE inhibitors are administered orally, all of them. Never IV, never IM, never sub-Q, orally, every single one of them. Contraindications and cautions to ACE inhibitors. Obviously, we're not going to give it to any patient that has an allergy to ACE inhibitors. If they have impaired renal function, we're not going to give this medication, right? Heart failure. If they already have heart failure, we are not going to give this medication to the patient. Women of childbearing age who choose to use one of these drugs should be encouraged to use barrier contraceptives to avoid pregnancy while taking this drug. Barrier contraceptive as in what? Condoms. You're going to teach the patient, if she's of childbearing age, if she's taking ACE inhibitor, she needs to make sure she's using condoms. Use is contraindicated during pregnancy. Adverse effects of ACE inhibitors, there are lots of them. All right, the adverse effects of ACE inhibitors are related to the effects of vasodilation and alterations in the blood flow. Such effects include reflex tachycardia, chest pain, angina, heart failure, cardiac dysrhythmias, GI irritation, ulcers, constipation, liver injury, renal insufficiency, renal failure, proteinuria. Is there ever supposed to be protein in the urine?
No.
No. We see protein in the urine. We know there's a problem going on with kidneys, right? The kidneys are affected. Proteinuria, rash, alopecia, dermatitis, and photosensitivity. ACE inhibitors are generally well tolerated, but can cause an unrelenting non-productive cough, especially in people of African descent. So if the ACE inhibitors, what's that?
That's why you wouldn't prescribe it to that.
That's one of the reasons, because it does cause a cough that doesn't go away, but it's not as effective. We have better drugs on the market for people of African descent, such as a thiazide diuretic, but this is a big reason why. Captopril, Moexapril, and Peridompril, I pronounced that wrong, but you guys see that drug, are associated with more serious adverse effects. Captopril has been associated with a sometimes fatal pancytopenia. Let's stop right there. That pancytopenia. That word pan means everything. Pan, covering all. Cyto, cells, penia, a little bit. So all of the cells, patient has next to nothing. RBC, platelets, WBC, that's deadly, right? Pancytopenia, cough, and unpleasant GI distress. Moexapril is associated with many unpleasant GI and skin effects, cough, cardiac arrhythmias, fatal, deadly myocardial infarction, and pancytopenia. It has sometimes been associated with this drug. And perindopril and lisinopril. And lisinopril is given often, right? This is a common medication. Look at this, guys. It's associated with sometimes fatal pancytopenia, as well as serious to fatal airway obstruction, found to occur more frequently in who? African Americans. You guys absolutely must know this, yes.
Sorry, what is PDS mean again?
A little bit. Think of PD, just a tiny little bit amount. You know what? Moving on. Page 742. Drug-drug interactions of ACE inhibitors. The risk of hypersensitivity reaction increases if these drugs are taken with allopurinol. We give allopurinol for what? Gout? Are you guys serious? You know what? Okay.
We haven't learned the drugs yet.
We haven't done gout yet?
No.
Okay, I forgive you.
Oh.
Yeah.
Ding ding ding.
There's a risk of decreased antihypertensive effects if taken with NSAID drugs. So the patient takes an NSAID, the ACE inhibitor may not work as effectively. All right, drug-food interactions. ACE inhibitors, they should be taken on an empty stomach 1 hour before or 2 hours after meals. Remember, they cause some serious GI upset, okay? Empty stomach, 1 hour before, 2 hours after meals. Nursing considerations for the patient on ACE inhibitors. Again, you're gonna make sure they have no allergies to ACE inhibitors. Their kidneys are functioning properly. So we're gonna be looking at the GFR, the creatinine, the BUN. We're gonna make sure they're not pregnant or breastfeeding. Their childbearing age, we're gonna make sure we teach them to use a condom. We're gonna assess their status baseline before starting therapy. You're gonna take vitals, you're gonna take their pulse, blood pressure, you're gonna check the ECG, you're gonna look at the CBC. Why is the CBC important? Why are you gonna look at the CBC before you give this drug? Pancytopenia, very good. You're gonna look at their serum electrolytes, because remember, what's that? Remember with this drug, there's a chance that it might cause just a slight decrease in potassium, but we want to keep an eye on the electrolytes. Implementation, you're going to encourage them to change your lifestyle. Again, exercise, eat right, lose weight, stop smoking, decrease alcohol and salt, start exercising. The medication, again, ACE inhibitors have to be given on an empty stomach 1 hour before or 2 hours after meals. Alert the surgeon and mark the patient's chart prominently if the patient's to undergo surgery. Look what it says. Why are we doing this? To alert medical personnel that the blockage of compensatory angiotensin II could result in hypotension after surgery that would need to be reversed with volume expansion. If they're on this medication, but they're going for surgery for whatever reason, there is a risk that that patient can become hypotensive. So we have to watch out for that. You're going to monitor the patient carefully in any situation that might lead to a drop in fluid volume, such as excessive sweating, vomiting, diarrhea, dehydration, because they're losing fluids. When your fluid goes down, your blood pressure is going to go down as well, right? We don't want that blood pressure to go down so low that the patient now goes into shock. You're going to provide comfort measures, give small frequent meals, access to bathroom, especially if they're on diuretics, bowel program if needed, environmental control, safety precautions, all that good stuff. All right, so we're going to switch gears. We talked about ACE inhibitors. Now we're going to talk about ARBs, angio-2 receptor blockers. So make sure you know all of these drugs that fall under the ARBs category. They end in sartan, such as losartan. Therapeutic and actions and indications. The ARBs selectively bind with angiotensin II receptors in the vascular smooth muscle to block vasoconstriction and the release of aldosterone. These actions block the blood pressure raising effects in the renin angiotensin system, and they lower blood pressure. Pharmacogenetics, again, these agents are all, ding, 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 that word all, they are all given how?
Orally.
Orally. Never IV, sub-Q, IM. They're all given orally. Contraindications and cautions. Allergy to the drug. If their liver, kidneys not working. Hypovolemia. Why would you give an ARB or even an ACE inhibitor to a patient whose blood pressure is already low? Who has a low, because hypovolemia does not mean low blood pressure, but low fluid volume. You know, if the volume is low, the blood pressure is going to be low. So we're not going to give an ARB to a patient who has low fluid volume. Where else would it be contraindicated? If the woman's pregnant. Again, women of childbearing age should be advised to use barrier contraceptives, a condom, to avoid pregnancy. If a pregnancy does occur, the ARB should be discontinued how? Immediately. Adverse effects. Adverse effects most commonly associated with ARBs include headache, dizziness, syncope, weakness, which could be associated with the drops in the blood pressure, hypotension, GI complaints, including diarrhea, abdominal pain, nausea, dry mouth, and tooth pain. Symptoms of upper respiratory tract infections and cough, rash, dry skin, and alopecia. Drug-drug interactions. The risk of decreased serum levels and loss of effectiveness if taken in combination with phenobarbital, indomethacin, or rifamycin. There may be a decrease in anticipated anti-hypertensive effects if the drugs combined with ketoconazole, fluconazole, or diltiazem. Sorry. Thank you.
Thank you so much.
No problem. These drugs should not be used with ACE inhibitors or Renin inhibitors because of the potential for serious adverse effects. So this is the second or third time that they made it very clear, we do not ever give ACE inhibitors and ARBs to the same patient. E744, nursing considerations for the patient taking ARBs. Again, you're going to assess them for allergies, kidney liver dysfunction, pregnancy and lactation, hypovolemia. If they have low fluid volume, we are not going to give them that ARB. We're going to take their baseline, we're going to take their vitals, implementation rationales. We're going to encourage the patient to implement lifestyle changes. Again, lose weight, stop smoking, increase exercise, decrease salt and alcohol in the diet. If they're having surgery, you're going to alert the surgeon and mark on the patient's chart prominently. That means so everyone can see if the patient is to undergo surgery. You're going to ensure that a female patient is not pregnant before they start this medication. So how are we going to make sure they're not pregnant? What test are we going to run?
Ecg.
HCG, very good. And then we're going to teach them to use a barrier method, a condom, so they don't get pregnant. If she gets pregnant, she has to stop taking that med immediately. Find an alternative method of feeding the baby if she's breastfeeding. She can't breastfeed while taking this medication. She better switch to formula. Monitor patient carefully in any situation that might lead to a drop in fluid volume. Remember, guys, I told you, whenever they give you examples, that means you need to know it. Examples are beautiful, select all that applies. So what are the examples that we would have to monitor the patient for a drop in fluid volume? Excessive sweating, vomiting, diarrhea, dehydration, anything that's making them lose lots of fluids. We're going to provide comfort measures such as small frequent meals, access to the bathrooms, especially if they're taking diuretics. We're going to do safety precautions, environmental controls. Environmental controls, guys, remember one of the things that can affect blood pressure is just hearing loud noise. That could increase their blood pressure, right? You're going to put the patient in a nice, calm, quiet environment, kind of like this room, how the lights are nice and dim, right? This type of patient, you will have the next to the nurse's station or down the hall. Down the hall, where it's nice and quiet. You're gonna do appropriate skin care, analgesics as needed. All right, we're moving on to calcium channel blockers. Calcium channel blockers, they decrease blood pressure, cardiac workload, and myocardial oxygen consumption. The effects of these drugs on cardiac workload also make them effective in the treatment of angina, that chest pain. Therapeutic actions and indications of calcium channel blockers, they inhibit or they block the movement of calcium ions across the membranes of myocardial and arterial muscle cells, altering the action potential and blocking muscle cell contraction. This effect decreases myocardial contractility, it slows cardiac impulse formation in the conductive tissues, and relaxes and dilates the arteries. Remember, constriction causes increased blood pressure. So the minute it stops that constriction, it's going to help the blood pressure go down. And then on top of that, it relaxes and dilates the arteries, which makes the blood pressure go down. It causes a fall in the blood pressure and a decrease in the venous return, which causes less workload of the heart muscle itself. Box 43.8. Trying to get rid of this glare. That's okay with this? All right. Several drugs that are used to treat hypertension cannot be cut, chewed, or crushed. Some antihypertensives need to, how can I see? Some antihypertensives to be aware of are diltiazem, I can't pronounce the drug, isradipine, the cardipine, the fetapine, the saldipine, and verapamil. These are what, guys? What class of drugs are these? Calcium channel blockers. Contraindications and cautions of calcium channel blockers. Allergies, heart block, sick sinus syndrome, renal hepatic dysfunction, pregnancy. Again, if the mother she just had baby, she's breastfeeding, another method of feeding the infant should be used if these drugs are required during lactation. She can't take medications. Adverse effects of calcium channel blockers. Dizziness, lightheadedness, headache, fatigue. GI problems include nausea and hepatic injury related to direct effects on the hepatic cells. Cardiovascular effects include hypotension, bradycardia, peripheral edema, heart block, skin flushing. All of these guys, when it comes to the calcium channel blockers, I want you to think of safety. Patient taking these calcium channel blockers are at risk for having hypotensive reactions and falling. We don't want them to have hypotensive reaction while they're driving or operating heavy machinery. So you need to think safety, safety, safety. Drug-drug interactions. A potentially serious effect to note is an increase in serum levels and toxicity if cyclosporine is taken with diltiazem. Drug-food interactions, you have to know this. This has shown up on NCLEX before. The calcium channel blockers are a class of drugs that interact with what? With grapefruit juice. Make sure you have that on your drug card because it's very important for you to know. When grapefruit juice is present in the body, the concentrations of calcium channel blockers do what? Increase, sometimes to toxic levels. You're going to advise the patient to avoid, ding, 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 avoid the use of grapefruit juice if they're taking calcium channel blockers. If a patient on a calcium channel blocker reports toxic effects, ask whether he or she has been drinking grapefruit juice. Page 746. They give you a case study about an African-American patient. starting on a diuretic because the lifestyle changes, that didn't work, so we had to move to choice 2, where you do the step 2, excuse me, where you do all of the lifestyle modification, plus you go on medication. And remember, because this is an African American patient, our first line, the golden drug of choice is going to be a diuretic, a thiazide diuretic, right? So they started on a diuretic in addition to the lifestyle changes. Let's jump to page 747. What are the teaching we're going to give to this African American patient that has been started on the diuretics? High blood pressure is a disorder that may have no symptoms. Remember, that's why it's called silent killer, but can cause serious problems such as heart attack, stroke, or kidney problems if it's left untreated. You're going to teach them to take the medication every day. Even if you feel good without the medication, you still need to take your medication as ordered. You're going to teach them this drug should be taken on an empty stomach an hour before or 2 hours after meals. Teach them the common effects of the drugs, and we went over all of these. I'm not going to go over them again. You see them. So this is important things that you're going to teach that patient about the diuretic. Okay, let's go back to page 746. And up here, it says nursing. Remember we talked about nursing considerations for the calcium channel blockers? This box says see chapter 46 for the nursing consideration for calcium channel blockers. So I put the page number right here, page 805 to 806. Let's jump there because that's some important information you need to know regarding the calcium channel blockers. So jump to page 805. I don't know why the authors of the book did this. Was that? I mean, why would, if anything, I understand if you wanted it in the chapter 46 because it does belong there, but you could have just added it into the chapter as well. Yeah, they don't know. Nursing students are lazy. I know if I didn't put this here for you and go over it, you guys wouldn't have done it.
No.
All right, so here we are. Let's go over nursing considerations for the calcium channel blockers. Again, make sure there are no allergies. Make sure there's no liver kidney dysfunction. Make sure they don't have heart block, because remember how this the action of the calcium channel blockers. Make sure they're not pregnant. Make sure they're not breastfeeding. We're going to do a physical assessment. We're going to assess their skin. Assess the patient's complaint of pain, including onset, duration, intensity, and location, and measures used to relieve the pain. Investigate activity level before, prior to, and after the onset of pain. Why? To aid in identifying possible contributing factors to the pain and its progression. That's important. That's on NCLEX.
Why are they in pain?
That's what we need to find out.
I mean, but why would they have
Like
pain?
other things happening.
Because it's used for angina.
Yeah.
Oh,
Heart pain, chest pain. What's that? So with this, we're going to investigate further, and most likely, what is that doctor is going to do? They're going to do an ECG. Assess cardiopulmonary status closely. Wait, let me back up because I don't want to skip over this because it's very important for you guys to know. Whenever that, and they should have put chest pain there, but what it is. Whenever a patient reports pain, one of the first questions you need to ask is, when did it start? What type of pain was it? How long did the pain last? What were you doing when the pain started? What did you do that made the pain go away? All of these information is very important because that's what you're going to provide to the doctor or the nurse practitioner for them to decide what kind of test they're going to run or what type of medication they're going to put that patient on. These questions right here, they show up on NCLEX. You have to know that that's what you're going to ask. You're not going to run and perform a nursing intervention. You need more information. If this information right here was not provided to you in the body of the question, you're asking it. That's what you're doing. Okay. All right. You're going to assess cardiopulmonary status closely, including their pulse rate, blood pressure, heart rate, rhythm. You're going to do an ECG as ordered, monitor respirations, and also take lungs. we want to make sure that patient didn't go into heart failure and all that fluid backed up into their lungs, right? We want to make sure those lungs are clear and we're not hearing crackles. Are we ever supposed to hear crackles? No. We're going to monitor lab test results, including liver and renal function tests. Oh, sorry. Try to think it out. You're going to monitor patient's blood pressure, cardiac rhythm, cardiac output closely. Monitor blood pressure carefully. Provide comfort measures. Again, guys, small frequent meals, environmental controls, limiting light. Remember, we want them in a nice, dimly lit area, no noise, maintain temperature, avoid excessive noise interruptions. You're not going to have them right next to the nurse's station where family members are doing the most. Healthcare providers are giving orders, nurses are talking. You're going to have them at the end of the hall. Safety precautions such as providing rest periods and assisting with ambulation if dizziness occurs. And I don't see it here, but you're going to make sure you teach that patient to move slowly. If they're getting out of bed, they can't just jump up out of bed, right? They're going to dangle and then get up slowly so they don't have orthostatic hypotension. Key points. Oh, we don't need key points. Oh, yes, we do. Calcium channel blockers block muscle contraction, and that's how it decreases the blood pressure. Patients on calcium channel blockers need to be monitored for signs of decreased cardiac output and response, including slow heart rate, hypotension, dizziness, and headache. All right, now we can go back to the page 746. Now we're going to talk about vasodilators. How do you pronounce vasodilators or vasodilators? Vaso, okay.
Also,
All right, vasodilators. If other drug therapies do not achieve the desired reduction of blood pressure, it's sometimes necessary to use a direct vasodilator. Guys, that just told us a lot. That just let us know that vasodilators are not first-line drugs used. Look at what it says. If other drug therapies do not achieve desired blood pressure. Okay, so this is not a first-line drug that we're going to use. We're going to use this drug if nothing else works. Then we're going to go to the vasodilators, right? Most of the vasodilators are reserved for use in severe hypertension, malignant hypertension, or hypertensive emergencies. These include your hydralazine, this other drug, minoxidil, and nitroprusside. So you guys need to know these drugs as the vasodilators. Therapeutic actions and indications. The vasodilators act directly on vascular smooth muscle to cause muscle relaxation, leading to vasodilation and drop in BP, page 748. They're indicated for the treatment of, what's that word, guys? Severe hypertension that has not responded to other therapy. So we use this as our last option. It's not our first line drug. Pharmacogenetics. So nitroprusside is used how? IV. And it makes sense because we're only giving these drugs in severe situations. We need it to work immediately. It's an emergency. Hydralazines available oral, IV, and IM. And minoxidil is available as an oral agent only. So we're not giving it any other way. Contraindications and cautions for vasodilators. We're going to check for any allergy to the drug, any condition that can be exacerbated by a sudden fall in blood pressure, any condition that the patient has that we can't afford for them to have a sudden fall in blood pressure, such as cerebral insufficiency. Patient has cerebral insufficiency. Let's say they're in a coma. Let's say they've got increased intracranial pressure, whatever it is. We can't afford for that blood pressure to drop suddenly because that patient will go into seizures. Okay? Caution should be used in patients with peripheral vascular disease, coronary artery disease, heart failure, or tachycardia. All of these can be exacerbated with a sudden drop in blood pressure. Remember, guys, these drugs are so strong, it will drop that blood pressure suddenly like that. That's why it's not our first line treatment. It can make a patient bottom out. Contraindicated in pregnancy. If they're needed by a nursing mother, the mother is going to have to use another form of feeding the baby. Adverse effects of vasodilators. Lots of them. Dizziness, anxiety, headache, reflex tachycardia. Remember, when we see that reflex, it does the opposite of what we wanted to do, just as a reflex, right? Heart failure, chest pain, edema, skin rash, lesions, abnormal hair growth with minoxidil, GI upset, nausea, vomiting, cyanide toxicity, such as, and in parentheses, you see dyspnea, headache, vomiting, dizziness, ataxia, loss of consciousness, imperceptible pulse. So they have a pulse, but we can't even catch it. Absent reflexes, dilated pupils, pink color, distant heart sounds, shallow breathing. And all of those can occur with nitroprusside. So nursing considerations for patients taking vasodilators. Again, we're going to assess them for allergies, impaired kidney or liver function, pregnancy and lactation, cardiovascular disease. We're going to assess baseline status before beginning therapy. We're going to take their vitals, ECG, implementation, the rationale. For patients taking vasodilators, we're going to encourage them again, lifestyle changes including. How many times have we seen this, guys? You think this is going to be on your test?
Yeah.
Yes, it will. Weight loss, smoking cessation, decreased alcohol, decreased salt in the diet, increased exercise. We're going to teach them to monitor their blood pressure, to keep a blood pressure diary at home. We're going to monitor their glucose and electrolytes. We're going to monitor the patient carefully in any situation that might lead to a drop in fluid volume. Anything that's going to make them lose fluid, such as vomiting, diarrhea, all that good stuff that we've talked about already. Comfort measures, we've talked about that a million times, right? Dim lighting, little bit of noise, make sure that they have access to bathrooms. All right, let's talk about diuretic agents, page 749. You guys need a 10-minute break or you good? What's that? Okay, we'll finish the chapter without getting a 10-minute break. All right, diuretic agents. Diuretics are drugs that increase the excretion of sodium and water from the kidney. So the first one we're going to talk about are sympathetic nervous system blockers. Remember that S in sympathetic, what did I tell you to think of when you see it? Squeezing.
Oh, squeezing.
And squeezing does what to the blood pressure? Increase blood pressure. So these drugs block that squeezing that will block that blood pressure from going up. That makes sense, right? All right. Drugs that block the effects of the sympathetic nervous system are useful in blocking many of the compensatory effects of the sympathetic nervous system. So first one are your beta blockers. They block vasoconstriction, decrease heart rate, decreases muscle contraction, and all of those help to decrease the blood pressure. Beta blockers are used to treat hypertension. We got to be careful though, because we're trying to bring that blood pressure down, but remember one of the effects is also decreasing that heart rate, right? So we have to be careful and be monitoring that heart rate as well. If the patient has hypertension, but they also have bradycardia, is a beta blocker a good idea to give? No, because it decreases that heart rate. Remember, before you give that beta blocker, you're going to take the apical pulse for a full minute. And if it's less than 60, are you going to give that beta blocker? No. All right, the next one is alpha and beta blockers. They block all the receptors in the sympathetic system. Patients can complain of fatigue, loss of libido, inability to sleep, and GI and genital urinary disturbances. The next one is your alpha adrenergic blockers. They can cause vasodilation, which leads to lowering of the blood pressure. The result is an increase in reflex tachycardia. So instinctively, your body will have a reflex from that low blood pressure, and then, and then your heart rate will go up. Because think about it, heart rate goes up, that's pushing more fluid out that can cause a domino effect to make the blood pressure go up, right? Reflex tachycardia, that occurs when blood pressure decreases. So we got to watch out for that when it comes to the alpha adrenergic blockers. Alpha 1 blockers. Before we even talk about the alpha 1 blockers, guys, actually, no, see that. So alpha 1 blockers, they block postsynaptic alpha 1 receptor sites. They promote a vasodilation, leading to a decrease in blood pressure. And then you have alpha 2 agonists. They decrease sympathetic outflow from the CNS and result in decreased blood pressure.
Professor, do you want the screen?
One second.
Thank you.
Can I scroll down to the key points? Diuretic agents lower blood pressure by various mechanisms, but all lower blood plasma. The ACE inhibitors prevent conversion of angiotensin 1 to angiotensin 2, and that's how it brings down the blood pressure. That's like 4 or 5 times we see the action of the ACE inhibitors. You guys have to know the action of the ACE inhibitors. Don't confuse that action with the action of the beta blockers versus the action of the ARBs versus the action of the vasodilators. Hint, hint, hint. You're going to be asked to know the difference. Maybe a match game or something. All right.
It's not getting crazy.
Let's not get crazy. ARBs prevent the body from responding to angiotensin 2. Renin inhibitors block the whole system by inhibiting the release of renin. And calcium channel blockers interfere with the influx of calcium. All right, so everything we've been talking about, guys, have been anti-hypertensive drugs, right? Now we're going to switch gears and talk about anti-hypotensive drugs. So now we're fighting decreased blood pressure and we're trying to bring the blood pressure up. Okay? The first choice. Remember I told you guys whenever you see first or first line, that's important to know, right? The first choice drug for treating shock is usually a sympathomimetic drug. Sympatho squeezing, mimetic, when you think of mimetic, I want you to think of pretending to be or something like, right? So it's a drug that acts like those sympatho action, which is squeezing, contraction, increasing blood pressure. All right, those are going to be our first line drugs to treat hypotension. So we're going to start with sympathetic adrenergic agonists or vasopressors. Sympathomimetic drugs are the first choice, ding, 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 first choice for treating severe hypotension or shock. Sympathomimetic drugs are used to treat shock, and they include, and they give you the list. I already showed you that, make sure you know it. Epinephrine's one of them. That's NCLEX asks about it a lot. Make sure you know it. Therapeutic actions and indications of the sympathomimetic drugs. They increase blood pressure, increase blood volume, and increase strength of the cardiac muscle contraction. So I want you to think about it. If the heart is just beating like this, right, it's pushing a little bit of blood out to the system. But if the strength of the contraction is increased and is doing this, it's pushing a whole lot of fluid and blood out into the system, which was going to increase the blood pressure. Adverse effects, Decreased GI activity with nausea and constipation, increased respiratory rate and changes in blood pressure, headache, changes in peripheral blood flow with numbness, tingling, and even gangrene in the extremities. These drugs should be used with caution with any disease that limits blood flow with tachycardia or with hypertension. And it makes sense. If the patient has any disease where they have limited blood flow, right? And here you are, you give a drug that causes vasoconstriction that, yes, increases the blood pressure, right? But what happens, for example, those vessels in the lower extremities where those toes need that perfusion? They're not going to get as much as it would if there was vasodilation and they have those blood pooling. Do you understand why? So it makes sense where we have to be very careful when the patient has any type of disease where, you know, blood flow is obstructed. All right, so blood pressure rate raising agents. Midodarine is an alpha-specific adrenergic agent used to treat orthostatic hypotension. Therapeutic actions and indications. It increases vascular tone and increases blood pressure. Contraindications and cautions. Remember, midodrine helps with orthostatic hypotension, but it's contraindicated in the presence of supine hypertension, which makes sense. We're giving midodrine for low blood pressure when you're moving, your blood pressure drops, right? To increase your blood pressure. So why would we give it to a patient that has hypertension? Does that make any sense? Are we trying to give them a stroke? So it makes sense. So we're not going to give it to patients that have supine hypertension, coronary artery disease. Why? Because remember, in coronary artery disease, there's already problems with blood flow. Or pheochromocytoma because of the risk of precipitating a hypertensive emergency. We're not going to give anyone who has renal disease, urinary retention, thyrotoxicosis, pregnancy, lactation, patients with visual problems. Remember, look how small these vessels are in your eyeballs. Renal hepatic impairment. Adverse effects. Piloerection, chills, rash, hypertension, bradycardia, dizziness, vision changes, vertigo, headache, problems with urination, which is why we're not going to give it to a patient who already has problems with urination, right? Drug-drug interactions. There's a risk of increased effects of toxicity of cardiac glycosides, beta blockers, alpha adrenergic agents, and corticosteroids if they are taken with midodrine. Which, remember, midodrine helps with what? Orthostatic hypotension. All right, next drug. Droxidopa. This is another blood pressure raising agent indicated for the treatment of orthostatic dizziness, lightheadedness, or feeling that you're about to black out. The actions and indications, you guys can read that on your own. Let's jump down to contraindications and cautions. When would we not give this drug? There are no contraindications to the use of droxidopa. We hardly ever see that, do we? Yeah. Caution should be used with any patient that has a history of cardiovascular issues. So it's not that we're not going to give it, but you know, as a nurse, you're going to remind the doctor, you're going to be like, oh, you know, this patient has heart issues, right? So we're just going to be cautious. Renal impairment. Nursing mothers should select a different method of feeding the baby because of the potential adverse effects on the baby. Adverse effects. The most common adverse effects associated with this drug are related to the sympathetic effects of the drugs. Remember, sympathetic causes squeezing, includes supine hypertension, headache. Wait, let me back up a little bit. Supine hypertension, which is why we wouldn't give this to a patient who already has it, right? Right. All right. Headache, dizziness, nausea, and arrhythmias. Drug-drug interactions. There is a risk of increased effects of droxidopa if it's combined with any, I'm not even going to try to pronounce the word, dopa Dopa decarbolize. You guys see it. This drug. Don't combine them. Listen, I've come to terms with my speech impediment. It is what it is.
That's mine.
All right, so nursing considerations for anti-hypotensive drugs. We're gonna make sure they don't have any allergy, impaired kidney or liver dysfunction, cardiovascular dysfunction, vision problems, urinary retention, pheochromocytoma. We're gonna assess their baseline status. We're gonna take their blood pressure, do all our vitals on the patient. We're gonna monitor blood pressure carefully because remember, we're giving this drug to increase the blood pressure, but we don't want it to work too well where we cause them to have a stroke. Do not administer the drug to the patients who are bedridden, but only to patients who are up and mobile. Think about it. We're giving this drug to patients that have orthostatic hypotension, which means when they get up, their blood pressure drops. If they're bedbound and they're not going anywhere, why would we give this to them? Does that make any sense? Okay, so don't fall for it. If you get a test question and they clearly tell you that this patient is bedridden. All right. Monitor heart rate. You're going to monitor a patient with known visual problems carefully. Encourage patients to avoid before taking a dose of the drug. We would avoid urinary retention. You're going to provide comfort measures. We talked about those comfort measures a million times. Key points. Midodrine and droxidopa are oral drugs used to treat people with orthostatic hypotension whose lives are considerably impaired by the falling blood pressure when they what?
Stand.
When they stand. So we are not going to give it to anyone that's bedridden. Summary. The kidneys activate the renin, angiotensin, and aldosterone system when blood flow to the kidneys is decreased. Again, essential hypertension has no underlying cause. About what? 90% of people that have hypertension have this. Okay, let's take a 10-minute break, and then when we come back, the last chapter for today, chapter 44. Did we do 44? Week is the renal, the
50, 51, 52.
yeah. 50, 51, 52.
Did you get it?
All right, chapter 44. How many drugs did you guys have on your drug list so far? Was it 6? All right.
That was fun.
Yeah,
Yeah, right. You wish. So, page 756, number 7 is going to be your cardiac glycoside. You absolutely know when they talk about cardiac glycoside, they talk about digoxin. And that's a perfect example of what I was telling you earlier when I was telling you that they might just give you a class. They say cardiac glycoside, you need to be thinking most likely they're talking about digoxin. You absolutely need to make that as your part. So that's number 7.
Yep.
All right. All right, you guys made out like bandits this week. You guys are only going to have 7 drug cards. Page 757. So we talked about heart failure already. Heart failure is a condition in which the heart fails to pump blood around the body effectively. Any failure of the muscle to pump blood out of either side of the heart can result in a backup of blood. If this happens, the blood vessels become congested. Eventually, the body cells are deprived of oxygen and nutrients, and waste products build in the tissues. Remember, the waste products are supposed to go where? In the urine for excretion, but they stay right there in the blood. Heart failure can occur with any disorders that damage or overwork the heart muscle, such as, and we're going to go through these different conditions. The first one we're going to talk about is coronary artery disease. Remember, those coronary arteries are the arteries that feeds the actual heart muscle itself. It's the leading cause of heart failure, accounting for approximately 95% of cases diagnosed. Next, cardiomyopathy. Cardio, heart, myo, muscle, opathy lets you know like disorder, right? So disorder of the heart muscle. It's a disease of the heart muscle that leads to an enlarged heart. That heart gets engorged. That enlarged heart is called cardiomegaly. And eventually, it turns to complete muscle failure and death. Next, hypertension. Hypertension eventually leads to an enlarged cardiac muscle because we talked about that. Remember how those muscles get thick? Enlarged cardiac muscle because the heart must work harder than normal to pump against the high pressure of the arteries. What else can cause heart failure? Valvular heart disease. Valvular heart disease leads to an overload of the ventricles because the valves don't close tightly and it allows blood to leak backward into the ventricles. Remember, when those ventricles squeeze, when they contract, it's supposed to push blood out, and then those leaflets are supposed to close all the way. And they don't, so instead of closing like this, it's like this, and some of the blood leaks back downwards, okay? The end result of all of these conditions is that the heart muscle cannot pump blood effectively through the vascular system. If the left ventricle pumps inefficiently, it backs up into where? The lungs. Left is for lungs. And in severe cases, the patient can have pulmonary edema. You'll hear rales, wheezing. You can see blood-tinged sputum. Patient can have low oxygenation and development of a third heart sound. You have to know that S3. You're supposed to have lub-dub, lub-dub, lub-dub. That's your S1, S2, S1, S2, S1, S2. You hear that S3, that might be indicative of congestive heart failure, okay? If the right side, remember how left stood for lungs, R stood for rest of body. If the right side of the heart is a primary problem, blood backup in the venous system leading to right side of the heart. Liver congestion, edema of the legs and feet reflect right-sided heart failure. Because the cardiovascular system works as a closed unit, one-sided heart failure, if left untreated, eventually leads to both sides and the signs and symptoms of total heart failure. Clinical manifestations. The heart rate will be rapid secondary to sympathetic stimulation, and the patient may develop atrial flutter or AFib as atrial cells are stretched and damaged. So the heart is trying its best to pump out all this fluid. So you may see an increase in the heart rate because it's trying its best to get rid of all that fluid. Anxiety often occurs as the body stimulates the sympathetic stress reaction. You have all this squeezing happening because it's trying to get all that fluid out. Heart murmurs may develop when the muscle is no longer able to support the papillary muscles that support the valve leaflets. Page 759. Peripheral congestion and edema occurs as organs and vessels become engorged. You're full with fluid, waiting for blood to be pumped through the heart as a result of pump failure. With right-sided heart failure, remember right is rest of the body. With right-sided heart failure, there's enlarged liver, that's your hepatomegaly, enlarged spleen, that's your splenomegaly, decreased blood flow to the GI tract, which causes feelings of nausea and abdominal pain, swollen legs and feet, and dependent edema in the coccyx and other dependent areas with decreased peripheral pulses, and hypoxia of those tissues. Why? Because they're not getting the oxygen they need. Now, in contrast, in left-sided heart failure, remember left is for lungs, edema of the lungs reflected in engorged vessels and increased hydrostatic pressure throughout the cardiovascular system. Okay? So let's start with a left-sided heart failure. Left is for what? Lungs. Very good. So signs and symptoms you expect to see in left-sided heart failure: tachypnea, dyspnea, orthopnea, hemoptysis, pulmonary edema. Take a look at this. This is a beautiful figure, 44.3. Look at this difference. Look at left-sided, we're seeing all these lung issues. And of course, patients going to have anxiety. When you have anxiety, if You could hardly breathe. Tachypnea, dyspnea, orthopnea, hemoptysis, Rales, S3, that's a big one. You hear lub dub and then you hear third heart sound, you better be thinking heart failure, left-sided heart failure, right? And then right-sided heart failure, which is the rest of the body. Look at those symptoms. The same things you see in patient with fluid overload, elevated jugular venous pressure, splenomegaly, hepatomegaly, pitting edema, fatigue, weakness. Page 760, right-sided heart failure. It usually occurs as a result of chronic obstructive pulmonary disease or other lung diseases that elevate pulmonary pressure. And right here on the side, I wrote left usually goes first. Usually patient has left-sided heart failure and it develops into right-sided. So the whole heart fails, but usually it starts at the left. It's also commonly seen with aging when the venous system fails to deliver blood to the heart effectively. Again, look at those signs and symptoms for right-sided heart failure: distended neck veins, hepatomegaly, splenomegaly. Dependent areas develop edema or swelling of the tissues, pitting edema of the legs, nocturia. So let's talk about treatments for heart failure. Cardiotonic drugs. Cardio, which means drug, tonic, tone of the muscle of the heart. Okay, so these drugs act on the muscle tone, right? Cardiotonic drugs, also called inotropic drugs, and for testing, they usually use inotropic. I hardly ever see them say cardiotonic, but make sure you guys know both terms. They work directly to increase the force of the muscle contraction. And the HCN, what's HCN stand for? I hate when they do this. Anyone see HCN, what they're talking about? I'll probably figure out as I read. But anyway, and the HCN blockers, which alter the heart's pacemaker and slow the heart rate. Other drug therapy used to treat heart failure include the following. Go over that list. If a person can tolerate it, the first goal, remember what I told you when they tell you first, second, third, pay attention. So the first goal would be to decrease the work on the heart. Vasodilators such as ACE inhibitors and nitrates decrease cardiac workload, relax vascular smooth muscle to decrease afterload, and allow cooling in the veins. Diuretics decrease blood volume, which decreases venous return and blood pressure, resulting in decreased afterload, preload, and cardiac workload. Beta blockers, all these drugs we've learned about. Beta blockers been approved for heart failure. Beta adrenergic agonists, they increase calcium flow into the myocardial cells and cause increased contraction, a positive inotropic effect. We want those muscles working, right? We want them doing what? Squeezing, contracting. Get that fluid out. Human B-type natriuretic peptides, leading to dilation and resulting in decrease of venous return, peripheral resistance, and cardiac workload. Take a look at box 44.1, where it says cultural considerations, drugs for heart failure. The drug Bidil is a fixed combination drug containing isorsabide, dinitrate, and hydralazine. Remember hydralazine, is that first line treatment drug that we give for hypertension or like last? Last, very good. This combination of vasodilators was studied in 1999, blah, blah, blah. Look at this. It was very effective in the subset of African American patients for heart failure. This combination of drug had a significant, as in important, impact in decreasing deaths and hospitalizations related to heart failure in African American patients. African American patients have been found to be less responsive. How many times have we seen this? Less responsive to ACE inhibitors, a standard therapy for hypertension than all others, and heart failure. This new combination showed promise for treating this population. Very important to know. Bidil should not be taken with any of the phosphodiesterase inhibitors, your sildenafil, varanafil, tadalafil because of the risk of serious hypotension. You guys recognize those drugs? Gentlemen, do you recognize those drugs? All right. Adverse effects that occur commonly with the use of this drug were headache, dizziness, orthostatic hypotension. Key points. All right, this one goes over the signs and symptoms, the difference between left-sided heart failure versus right-sided heart failure. I absolutely am going to kill you on these signs and symptoms on your test, so make sure you know it. Not on your test next week, but the test after that, whatever it's going to be, just know that you're going to get questions on it. You absolutely must know the difference between left and right-sided heart failure because NCLEX expects you to know that, okay? Cardiotonic agents. Cardiotonic, also known as inotropic drugs, affect the intracellular calcium levels in the heart muscle, leading to increased contractility. And that's wonderful because what happens is when the patient has heart failure, the heart is just doing this. It's pumping, but it's not really pumping effectively. It's not getting all that blood out. But when we give the drug to strengthen the contractility of the heart, all of a sudden that heart muscle that was doing that was doing this. It's really getting all of that fluid out to the body, okay? This increase in contraction strength leads to increased cardiac output, which causes increased renal blood flow and increased urine production. So not only are we getting this oxygenated blood out to the body where it needs to go, the kidneys are being perfused and the patient's able to get rid of that fluid as well. Two types of cardiotonic drugs are used. The classic cardiac glycosides, which have been used for hundreds of years, and the newer phosphodiesterase inhibitors. I can say this, but I can't say simple other words. But anyway, you guys got to know those two classes. So let's start with the cardiac glycosides. You only have one on there, guys. Digoxin. You better know digoxin. Oh my gosh. No digoxin like your life depended on it, okay? Therapeutic actions and indications of digoxin. You see how many stars in NCLEX I have all over this? All right, digoxin increases intracellular calcium and allows more calcium to enter the myocardial cells during depolarization, causing the following effects. You must know these effects. What are the effects of digoxin? Increased force of myocardial contraction. So it has a positive inotropic effect because it is actively working on that heart muscle. That heart muscle that was going like this is all of a sudden going like this and really getting that blood out to the tissues. Next, increased cardiac output and renal perfusion. It's getting all of the fluids out, and now all of the organs are being perfused, especially the kidneys. Look at this, increased cardiac output and renal perfusion, which has a diuretic effect. So we're also getting rid of the fluids, increasing urine output and decreasing fluid volume while decreasing the renin release and activation of the renin angiotensin aldosterone system. This just said a mouthful. So not only are we increasing the contractility of the heart, we're making that heart muscle stronger so it can push all that fluid out. Not only are we doing that, we're increasing perfusion to our kidneys, which makes us get rid of all the fluid that the body's having. And not only that, it blocks that renin angiotensin aldosterone system that makes the heart rate go up. Because usually when we have contraction going on, we're concerned about high blood pressure. But look at all of the things that this drug is doing. It's making that blood pressure not go up, while at the same time still stimulating myocardial contractility, while at the same time increasing perfusion, especially to our kidneys. All right. What else does it do? Look at this, guys. Even though it increases the contractility of the heart, look at this. It slows down the heart rate. It slows down the heart rate. So even though it increases that contractility, it pushes all of the fluid out. It increases perfusion to the kidneys. It decreases that RAS system so the blood pressure doesn't go too high. It slows down the heart rate. So you better be taking an apical pulse for a full minute. before you give this medication. Because if that pulse rate is 60, are you going to give that med?
No.
You're going to hold and call the doctor. It slows the heart rate, and last, it decreases conduction velocity, that push that it gives, okay? The overall effect to increase the cardiac output, which may relieve symptoms of heart failure in some people. Let me say that again. The overall effect is to increase cardiac output, which may relieve symptoms of heart failure in some people. Digoxin is indicated for the treatment of heart failure, atrial flutter, AFib, and paroxysmal atrial tachycardia. Now, I didn't see this anywhere in the book, but for NCLEX, I guarantee you have to know your ditch level. So I just wrote it to make sure you guys you know your normal ditch level, which is 0.5 to 2. Once you hit 2.4, you're at toxic levels. Thank you. Your normal ditch level is 0.5 to 2, but once you hit 2.4, that patient's going through ditch toxicity, okay? Digoxin has a narrow margin of safety, just like potassium, 3.5 to 5. Just like lithium, digoxin also has a very narrow therapeutic range, 0.5 to 2. Once you hit 2.4, you're in ditch toxicity. Contraindications and cautions for digoxin, which is a what? Cardiac glycoside. Cardiac glycoside, so any allergy. Digoxin is contraindicated in the following conditions. I don't know why I didn't highlight this. Can I borrow your highlighter, please? Thank you. We are not going to give digoxin if the patient has VTAC, VFib, heart block, sick sinus syndrome, idiopathic hypertrophic subaortic stenosis, myocardial insufficiency. They have any of these heart issues, we are not giving them digoxin, because although digoxin increases the contractility of the heart, what does it do to the rate? Slow it down. You think any of the patients that I just mentioned, any of this disorder, do you think they can afford for that heart rate to be slowed? No. Okay. We're going to check for renal insufficiency. Their kidneys have to be working properly, because remember how it affects on the kidneys. We're going to check for electrolyte abnormalities. Look what they gave us in parentheses. We're going to watch out for increased calcium, decreased potassium, decreased magnesium. You guys need to know this. So it's not enough just to know we're going to be watching out for electrolytes. We have to know which one specifically. Okay. Other contraindications or cautions: pregnancy, lactation. Let's talk about adverse effects. Headache, weakness, drowsiness, and vision changes. Yellow halo around objects is often reported. And I put a little star next to that because that's the one NCLEX seems to ask about, like if you recognize that. GI upset, anorexia, ditch toxicity. What's the normal range for ditch? Very good. What's the number if that's more and more toxicity? Very good, 2.4. Ditch toxicity is a serious syndrome. Remember when you see that word syndrome, guys? That just means a cluster of abnormal signs or symptoms, okay? So it's a serious syndrome that occurs when digoxin levels are too high. The patient may present with, this is a select all that applies on NCLEX. It's come up many times. You better know those signs and symptoms of ditch toxicity. Anorexia, nausea, vomiting, malaise, depression, irregular heart rhythms, including heart block, atrial arrhythmia, ventricular tachycardia. This can be a life-threatening situation. A digoxin antidote, you guys better know this. Digoxin immune fab, also known as digifab. That's the antidote. So if you get a test question and it tells you that this patient's been getting digoxin for X amount of time and they're exhibiting, and they give you the symptoms of ditch toxicity, and they ask you what medication do you expect the physician to order, it's going to be your digifab, this immune fab. Okay? That's your antidote. Drug-drug interactions. There's a risk of increased therapeutic effect and toxic effects of digoxin. If that digoxin is taken with verapamil, amiodarone, quinidine, erythromycin, tetracycline, cyclosporin. If digoxin is combined with any of those drugs, it may be necessary to decrease the digoxin dose to prevent toxicity, because those drugs make that digoxin work way stronger and can cause the patient to be ditch toxicity. If one of these drugs has been part of a medical regimen with digoxin and is discontinued, the digoxin may need to be increased, because remember, we're decreasing it if they're taking one of those drugs with it, but if one of those drugs are removed, we may have to go ahead and increase that level, okay? The risk of cardiac arrhythmias could increase if these drugs are taken with potassium-losing diuretics. Digoxin may be less effective if it's combined with thyroid hormones, metoclopramide, or penicillamine, and increased digoxin dose may be needed. Absorption of oral digoxin may be decreased if it's taken with cholecystyrene, charcoal, cholesterol, and acids. You guys see the list, make sure you know it. I'm not even going to try to pronounce these drugs. But more important, well, not more important, but just as important, look at this. It should not be taken at the same time, but should be administered 2 to 4 hours apart when you're taking oral digoxin with any of those meds. Box 44.6. Herbal and alternative therapies. St. John worts and psyllium have been shown to decrease the effectiveness of digoxin. This combination should be avoided. If the patient is taking digoxin, they shouldn't be taking any St. John worts or psyllium. Increased digoxin toxicity has been reported with ginseng, hawthorn, and licorice. Patients should be advised to avoid these combinations. And that's why it's so important to ask them if they're taking anything over the counter or any herbal remedies. So nursing considerations for cardiac glycosides, page 766. Assess for known allergies, impaired kidney function. We're not going to give digoxin if the patient has ventricular tachycardia or AFib, heart block, sinus syndrome, IHSS, MI. We're going to check for electrolyte abnormalities, specifically increased calcium, decreased potassium. And that's why, think about it. This drug can cause the patient to have decreased potassium, right? Aren't we going to be concerned if they're also taking something such as a Lasix, which makes you lose potassium, right? Or decreased magnesium. We're going to make sure they're not pregnant or breastfeeding. We're going to assess their cardiac status closely. We're going to take their vitals, especially blood pressure and heart rate. This is on NCLEX. Make sure you know it. You're going to monitor the apical pulse for 1 full minute. Not radial, it's going to be apical, and you have to do it for 1 full minute because, again, even though it increases the contractility of the heart, it slows down the heart rate. That's very important for you to know. Hold the dose. If the pulse is less than what? 60 in an adult or less than 90 in an infant. You're going to go back to this medication when you guys go to peds. You have to know this. Retake the pulse in 1 hour. And something they didn't put in there, but I'm telling you now, you're going to, for testing purposes, not only are you going to hold it, you're going to call the doctor and let them know. You're not just going to hold it, sit on it for an hour, then recheck. You're going to call the doctor and let them know. Then you're going to retake the pulse in an hour. If the pulse remains low, document it, withhold the drug, and notify the prescriber. You're going to check the pediatric dose with extreme care. You're going to do your math and check with another nurse. You're going to double check and make sure that your math was correct. Follow dilution instructions carefully for IV use. And use promptly because the medication breaks down very quickly. Administer IV doses slowly over at least 5 minutes because that medication can cause the patient to have dysrhythmia. You're going to give it very slowly. Avoid IM administration. Arrange for the patient to be weighed. at the same time, on the same scale, in the same type of clothes every single day. Remember, when it comes to heart failure, we really have to keep track and see if this medication is working. And the best way of keeping track of fluid status, I've told you this a million times, is daily weight, not INO, not skin turgor. It is daily weight. You're going to administer, avoid administering the oral drug with food or as acids. 1 hour before, 2 hours after. This is important. Look at this. Maintain emergency equipment on standby. Potassium salts, because remember, it can cause hypokalemia. Remember, potassium acts directly on what organ? The heart. So make sure you have potassium salts. Lidocaine for the treatment of arrhythmias. Phenytoin, which is dilantin, in case they go into seizures. Atropine to increase the heart rate. By the way, guys, I'm going to go over this next week, but you're going to have to know atropine. That's another one NCLEX asks about a lot. And we give this when that heart rate's too slow. We give that to increase the heart rate. And cardiac monitor. So all of these we're going to make sure we have right there on standby for that patient. You're going to obtain the DIG levels as ordered, monitor the patient for therapeutic digoxin level. Okay, they gave it to us right here, 0.5 to 2. I guess I was too hype, I couldn't wait. Yeah, they didn't put the antidote there, but you know you'd better have the antidote on hand. I'm not gonna say what I want to say, so I'll put don't sue me, but. Page 768. Phosphodiesterase inhibitors. The only drug currently available in that class of drugs is milrinone. Therapeutic actions and indications. The phosphodiesterase inhibitors block the enzyme phosphodiesterase. It increases calcium levels in the cell. Increased cellular calcium causes a stronger contraction, and it prolongs the effects of sympathetic stimulation. And remember, sympathetic squeezes, and it can lead, which can lead to vasodilation, increased oxygen consumption, and arrhythmias. Milrinone is indicated for short-term treatment of heart failure that hasn't responded to digoxin or diuretics alone, or that has had a poor response to digoxin, diuretics, and vasodilation. So let me ask you something. This phosphodiesterase inhibitor, milrinone, is this our first-line drug for heart failure? Is it even our second-line drug for heart failure? No, we're giving this when the other drugs don't work. Okay? Because this drug has been associated with the development of potentially fatal, as in deadly ventricular arrhythmias, its use is limited to severe situations when nothing else has worked. Pharmacogenetic is only available for IV. Remember, this is for emergency use. Contraindication and cautions. Allergy, aortic or pulmonic valvular disease, acute MI, fluid volume deficit, ventricular arrhythmias. We're going to use this with caution in patients for elderly, because remember, if they're elderly, their kidney and their liver function is not working the way it used to, right? Breastfeeding and lactation. Let's talk about adverse effects of the drug. The adverse effects most frequently seen with this drug are ventricular arrhythmia. So that's why we're not going to give it if the patient even has a history of this. What are other adverse effects? Hypotension, chest pain, nausea, vomiting, anorexia, abdominal pain. Thrombocytopenia. Thrombus, clots, cyto, cells. So we're thinking platelets, right? Penia, a little bit of. Patient can have decreased platelets, which can cause what? Bleeding. Thrombocytopenia can occur with milrinone. Hypersensitivity reactions include vasculitis, pericarditis, pleuritis, and ascites. Drug-drug interactions. Precipitates form when milrinone is given in solution with furosemide. What is furosemide, guys? Lasix, that's right. Avoid this combination in solution. We cannot give this drug with Lasix. Use alternate lines if both of these drugs are being given IV. Nursing considerations for the patient receiving phosphodiesterase inhibitors. You're going to assess for allergies. Make sure you don't give it to them if they have acute aortic or pulmonic vascular disease, acute MI, fluid volume deficit, ventricular arrhythmias, pregnancy, lactation. You're going to check their cardiac status very closely. You're going to take their vitals. Remember, you're going to take that patient's weight, same time, same clothing, same scale every single day. Monitor lab tests, including electrolytes. We're going to look at the CBCs. We're going to check their renal and liver function. Implementation rationale. When it comes to Melrinone, we're going to protect that drug from light because remember, it breaks down very easily. Ensure a patient has a paid IV access available. Remember, this drug's only given IV. You're going to monitor the blood pressure, pulse and blood pressure frequently. Monitor their INO. Monitor platelet counts. Why? Because remember thrombocytopenia. So we're going to be looking at those platelets. Monitor platelet counts before and regularly during therapy. Provide life support equipment on standby. Remember everything we talked about having on standby? Make sure you have it on standby in case patient has a severe reaction. Oh, there goes our HCN. Hyperpolarization, activated cyclic, nucleotide gated channel blockers, HCN blockers. Yeah, HCN, that's why.
I didn't want to write it down.
I was like, what is this HCN? That's what they're talking about. So let's talk about the HCN blockers. HCN blockers. This is medication, ivabradine. It does not affect muscle contraction, but it does affect the pacemaker of the heart. Now, guys, what's the pacemaker of the heart? The SA node. It affects the pacemaker of the heart to reduce the heart rate. Therapeutic actions. It slows the heart's pacemaker, again, the SA node. It allows more time for ventricular filling and improves cardiac output. The systemic effects seen with beta blockers are not seen with this class of drugs. Contraindications and cautions. Any allergy to ivabradine or bisulfites, the HCN blockers. Active decompensated heart failure, hypotension. This is important, guys. When it comes to HCN blockers, you are not going to give it to the patient if they have hypotension. 6, sinus syndrome, AV block. Resting heart rate under 60 beats per minute. If their heart rate is, and I know this says under, but for testing purposes, if it's 60, you're not giving this medication, okay? Patients completely dependent on a pacemaker, you're not going to give this medication because it works directly on the pacemaker of the heart. So if the patient has a pacemaker, is their SA node working the way it's supposed to? No. We're not going to give it if the patient has liver function. If they're on CYP3A4 inhibitors, caution should be exercised with AFib or moderate heart block. We're not going to give it if they're pregnant. If they're pregnant, women of childbearing age should be encouraged to use contraceptive measures such as condoms. We're not going to give it if the patient's breastfeeding. Let's talk about adverse effects of the HCN blockers. Adverse effects most frequently seen with this drug are bradycardia. That's why we're not going to give it if that heart rate is 60 or lower. We're not trying to make them bottom out. Hypertension, AFib, and luminous phenomena. This is sudden change in brightness in parts of their visual field, colored bright lights, image decompensation, seeing multiple images. Safety precautions need to be taken with the visual changes. Patients having those visual changes, you think it's a good idea for them to be on the road driving?
No.
No. Drug-drug interactions. Altered plasma concentrations occur with strong CYP3A4 inhibitors or inducers. And that's why we don't give this medication if they're already on that. Severe bradycardia can occur if combined with other negatively chronotropic drugs. So let's talk about nursing considerations for the patients receiving that drug that I can't even pronounce. Ivabradine. You guys see it right there. All right. So we're not going to give it if the patient has any allergies, if they have AV block, decompensated heart failure. If they're dependent on a pacemaker, we're not going to give because this drug acts directly on the patient's SA node. Resting heart rate under 60 beats per minute, hypotension, severe hepatic impairment. If they're currently taking CYP3A4 inhibitors, we are not going to let them take this drug. We're going to assess their cardiac status closely. We're going to take that patient's daily weight in the same clothes, same time, same type of, I said clothes already. So same time, same scale. There we go. We're going to assess their voiding pattern. We're going to check the lab tests, including the CBCs. Page 772. We're going to monitor their heart rate, blood pressure, I&O, and we're going to provide safety measures. Remember, they can have visual disturbances. So right here, limit driving. If they have these visual disturbances, they cannot drive or operate, God bless you, operate heavy or hazardous machinery. Key points. Stick with me, guys. We're almost done. Cardiac glycoside digoxin increases the movement of calcium into the heart muscle. You guys have to recognize that digoxin is a cardiac glycoside because for testing purposes, sometimes they're not going to say digoxin, they'll just say cardiac glycoside, and you are expected to know that's what they're talking about, okay? This results in increased force of contraction, which increases blood flow to the kidneys. It slows the heart rate. Next, phosphodiesterase inhibitors, they allow calcium to enter the cell, and that leads to more intense contractions of the muscle. Next, milrinone. This is the only phosphodiesterase inhibitor that's available and is associated with severe effects. That's why it's our last line treatment. It's reserved for use in extreme situations. And remember, it can only be given how? IV. Very good. Let's take a look at the summary. First line medication therapy for heart failure would be to decrease the workload of the heart with medications that decreases the preload, afterload, and heart rate. Cardiotonic inotropic agents are one class of drugs used in the treatment of heart failure. Cardiac glycosides, which is what? Digoxin, very good. Cardiac glycosides increase movement of calcium into the heart muscle. It results in increased force of contraction, which increases flow to the kidneys that causes a diuretic effect, but it also does what to the heart rate? Slows down the heart rate. All right, and that's it. You guys survived these chapters. Don't forget your test next week. Oh, let me shut out this video.